Good morning. My name is Bruce Nash. I'm the Chief Medical Officer of Capital District Physicians Health Plan, which is based in Albany, New York. CDPHP, as we are known, is a not-for-profit, physician-sponsored network model plan with close to 400,000 members who live in the 24 counties in upstate New York. We are the Capital District's largest provider of managed commercial, Medicare, and Medicaid products. I also serve as the chairman of the Medical Directors Council for the Alliance of Community Health Plans, or ACHP, whose members include 22 of the nation's leading nonprofit regional health plans who share our commitment to the triple aim, a concept created by the Institute for Healthcare Improvement, that is, improving the patient's experience of care, improving the health of populations, and reducing the per capita cost of care. CDPHP was founded by the physicians of the Albany County Medical Society 28 years ago, and to this day is governed by a board whose majority are practicing physicians who are elected by their peers. Our board chair is also required to be a practicing physician. As a consequence, we have enjoyed a close relationship with our provider community, enabling us to deploy market-leading initiatives that improve the care delivery for our members, despite not directly employing any of the clinicians. This has led to us being recognized as a top-ranked health plan in the state and the nation for our member satisfaction and quality metrics. 4 years ago, our board emerged from a strategic planning session with a directive from management to address the impending primary care crisis. It was noted that our local medical school was no longer graduating significant numbers of new physicians who were choosing primary care as a career. While the causes for this were multiple, we chose to focus on improving a primary care physician's income potential. It was clear for this to be accomplished, it would have to be funded by changing the way physicians practice with more effective and efficient care as a result. This began the program that we later labeled our Enhanced Primary Care Program, or EPC. We began with an initial pilot of 3 practices, and over a 2-year period of time, we're able to demonstrate an improvement of 14 of 18 specific quality metrics, a 15% reduction in hospital utilization, a 9% reduction in emergency department usage, a 7% reduction in the use of advanced imaging. All of this resulted in an $8 per member per month savings in total health care costs. On the strength of these early data, CDPHP expanded its EPC program by establishing training programs for selected practices lasting 12 months and requiring significant commitment of time and effort from the practices as they learn the basics of enhanced primary care. We currently have 75 such practices representing 384 providers and almost 100,000 of our members. We're now launching our next cohort which will add an additional 70 practices. While much of what I've described is common to many successful patient-centered medical home initiatives nationally, we believe our unique contribution to this effort has been the creation and deployment of a novel reimbursement methodology. This model involves a risk-adjusted global payment for all services that the physician provides in conjunction with a significant bonus based upon the elements of the triple aim: the patient's experience of care, the quality, and the cost efficiency. It creates an opportunity for a physician to enhance his or her reimbursement by, on average, 40%. Our base payment is a unique global payment to the practice for each of their patients. If this is driven by a severity factor that was developed for our use by the scientists associated with Verisk Health, Inc., a global analytics firm. This severity score predicts the amount a primary care physician should be paid for a specific patient based upon the diagnoses of that patient. This score is then multiplied by a conversion factor to determine the payment for that given patient based upon their plan type, that is, commercial Medicare or Medicaid, and we pay this to the practice on a monthly basis. We still pay fee-for-service for a small subset of physician services, about 15%. These payments represent things that we would like to incent the primary care physicians to do in their office as opposed to referring to a specialist, such as minor skin biopsies, or for the acquisition costs of things like immunizations. The bonus or pay-for-performance aspect of the model is focused on the triple aim. We measure the satisfaction of the practice's patients to determine the bonus eligibility for the practice. Currently, we utilize HEDIS metrics to measure the quality of care delivery. A weighted average of 18 distinct metrics creates a quality score for the practice. Our efficiency metric is an output of our impact intelligence software, which accomplishes the required risk adjustment across the total cost of care. The annual bonus payment to a practice is determined in a manner that has been described as a tournament system. Simply said, practices need to perform better than other practices in the network to achieve their optimal payout. Our initial data for the EPC program was based on a population of only 12,000 members. We are fortunate that the Commonwealth Fund has provided a grant to an external evaluator, Dr. David Bates of the Brigham and Women's Hospital, to evaluate our 2012 experience. These data will become available in the latter half of 2013. CDPHP has also been active in the development of alternative reimbursement models for certain specialist and hospital partners. While we have yet to develop the experience that we have with the EPC program, we firmly believe that all components of the delivery system need to engage with us in payment models that align financial incentives with the needs of our community. Thank you for inviting me to be here today, and I look forward to your questions.
Chair, thanks, gentlemen. And